Hi, everyone. Welcome to the University of New Mexico Department of Psychiatry and Behavioral Sciences Grand Rounds. Glad to see everybody today. And it is an honor for me to introduce our guest speaker today. A little background. One of the major reasons many of us are here is to work with our trainees. And we hope that we can teach them some things that they'll carry with them off to their careers. Some stay with us, and so some go off to faraway lands. And in both scenarios, we hope they make us proud. In many cases, they develop remarkable careers. Once upon a time, I had the honor of working with our speaker today during his residency, introducing him to a new paradigm I was learning, intensive short-term dynamic psychotherapy. We were both quite enthusiastic about what we were observing, enough to attract a senior clinician, Patricia Coughlin, to move here to New Mexico for a couple of years. Now our speaker has gone on to become quite the expert in this paradigm, training many residents himself and speaking nationally and internationally. So it's an honor to introduce to you Dr. Brandon C. Yarnes, MD, MS. Many of you remember Dr. Yarnes. He's now an assistant professor at the University of California, Los Angeles Department of Psychiatry and Biobehavioral Sciences and staff psychiatrist in the Geriatric Mental Health Section at the VA Greater Los Angeles Healthcare System. Dr. Yarnes completed a research fellowship and master's degree in research at UCLA, a geriatric psychiatry fellowship at Yale University, and as many of you remember, a psychiatry residency with us at the University of New Mexico. His areas of expertise include chronic pain, aging, psychotherapy, and clinical trials. He is a current VA Career Development Award recipient and the author of over 36 peer-reviewed journal articles, abstracts, and chapters. So with that, it is an honor to pass the baton over to you in Los Angeles, Dr. Yarnes.
Thank you very much, Dr. Katzman, for that very kind introduction. And I will just pull up some slides here. All right, and thank you all for being here as well. So I'm going to be talking today about my work in psychotherapy that, as Dr. Katzman says, really goes all the way back to him in my PGY2 psychiatry residency at UNM. So I am very honored and humbled to be here speaking to you in this role today. The title of my presentation is Recent Advances in the Psychological Treatment of Chronic Pain. And so I wanted to let you know that I do have a grant that is it is researching one of the treatments that we're going to go over today, which is called Emotional Awareness and Expression Therapy, or Eaet, which is very closely related, as you'll see, to ISTDP that Dr. Katzman mentioned and that I learned first from him. And our learning objectives for today, a little bit about chronic pain, a little bit about psychotherapy. We're going to talk about subtypes of chronic pain first. Then I'm going to talk a little about how relationships, stress in your life, emotions, and brain changes are related to certain subtypes of chronic pain that I'll go over. And then I'm going to talk about the assessment and treatment approach that we use in my research study that I talked about and here in Los Angeles to address chronic pain. And this includes an assessment approach to try to figure out if a patient's going to be a good responder for psychotherapy for chronic pain. And then I'm going to talk about two novel psychotherapy approaches for chronic pain reprocessing therapy, or PRT, and the emotional awareness and expression therapy, or EAET, that I mentioned. So I'm going to start with a case, and this is a real patient that we treated in our very last group EAET in Los Angeles here at the VA. And so he was a participant in our research study. He was 74 years old. All of our patients are 60 and up. Being a geriatric psychiatrist, I focus on treating older patients in the study and in my practice. And he was a veteran. So in 1984, he was involved in a major motor vehicle accident, and it resulted in his right arm being paralyzed. And so when he came in, it had some contractures and some muscle wasting, and his pain was also in that right upper extremity and his right shoulder. So that was the reason that he wanted to participate in the study. His baseline pain was very high at an 8 out of 10 on the 0 to 10 pain scale that we all know about. And he had a long history of being prescribed opioids and had a recent hospitalization, like right before he got into the study, for a pain exacerbation in which he was started on buprenorphine for his chronic pain because they thought he had developed an opioid use disorder as well. So on top of all of this, when he came in, he was in this motorized power chair for unclear reasons. There wasn't anything that we knew about in terms of pathology in his legs or paralysis there. It was all in the right arm where his problem seemed to be. So I'm going to keep coming back to this case throughout the presentation. And once I introduce the assessment approach, we'll talk about his assessment and his treatment course as well later on. But first, by way of background, I want to hit on about 4 points. The first one is what I mentioned about subtypes of chronic pain. What do you think about that there are different subtypes of chronic pain that we can determine? Most of the time, we think about chronic pain as chronic pain, and that's usually how it's written. But in the last decade or so, a little over that, people have said that there can be at least 3 categories or subtypes of chronic pain based on the presumed underlying mechanisms of the pain. And these 3 categories are now endorsed by the International Association for the Study of Pain, IASP, which puts out lots of definitions, like a definition of pain. What is it? So let me go over these 3 categories and see what you think. The first on the left there is called peripheral nociceptive pain. And what that refers to is a mechanism of pain that refers to damage in the peripheral tissues or dysfunction or inflammation in the peripheral tissues. So there is a real problem in the body, like a cancer pain, a burn pain, an infection like a vertebral infection, an autoimmune disease like rheumatoid arthritis, when there is hip osteoarthritis or knee osteoarthritis, when you've done a radiograph and there's clear evidence for it, that's a nociceptive peripheral condition. And these are usually responsive to medical surgical intervention or should be referred, like in the case of cancer pain, for some medical or surgical intervention. The second category is peripheral neuropathic pain, which is when there is damage or dysfunction to the peripheral nerves. So that's obviously the most common example is diabetic neuropathy or something like carpal tunnel syndrome that can also be responsive to medical or surgical procedures. Like in the case of carpal tunnel, there's a carpal tunnel release procedure that is reasonably effective. Then there's this third category that we think is patients that are more appropriate for psychotherapy. And this is when the chronic pain doesn't have a clear peripheral nociceptive or neuropathic cause that fully explains the pain. And our understanding is that it may be influenced by factors and changes in the central nervous system and particularly the brain. And so this is quite common. We think that most cases of musculoskeletal pain, like chronic low back pain, neck pain, even tension headaches, fit into this category. And also other things that involve pain, like irritable bowel syndrome, may include some nociplastic or centralized component, or interstitial cystitis, chronic pelvic pain. So these categories are kind of complicated when you are seeing an individual patient. And one of the confusing aspects is when the patient has been told that there is some really minor peripheral abnormality that explains their pain, but yet it doesn't really seem to fully explain the pain that they experience all over their body. And the confusing part is made clear is it's shown by these studies that go back to the early 1990s, showing that in the back, there are many minor abnormalities that people have who don't have chronic pain. So you see on this chart, this is from a systematic review in 2015, that if you look at my older adults here, age 70, 93% of them have some sort of degenerative disc disease, which means some sort of disc degeneration, even when they don't have chronic pain. So there's really a poor correlation between some of these peripheral findings, at least in the back, and chronic pain that patients experience. So it's not necessary in this approach to completely rule out all nociceptive pain. What we want to see if it fully explains the pain. So that's one point. The second point I want to make is going into the relationships between stress, emotions, the brain, and chronic pain. So chronic pain, you all are probably aware, has high overlap with emotional symptoms, emotional disorders, depression, anxiety, PTSD. There was one study down at the bottom, you see the citation for the Fishbane article, that showed 50% of veterans with chronic pain also have PTSD. But even those patients who don't have PTSD frequently have other symptoms that we broadly refer to as psychological or relational conflicts. And many of these things have been studied, such as adverse childhood experiences, certain psychological characteristics like alexithymia or perfectionism have been associated with chronic pain, and even some unusual things like keeping secrets has been associated with chronic pain, and lying in some studies. So there is a high prevalence of emotional, psychological, and relational issues in chronic pain patients. And all of these are more common in those conditions that I refer to as centralized chronic pain, that third category. In addition, what about the brain? So I think most of you are aware that if I pinch my finger like this until it hurts, that's going to light up my brain, and it lights up both sensory and emotional or affective brain regions in my brain. But what about chronic pain? So the Apkarian group of a neuroimaging group in Chicago, they took patients with chronic low back pain, which we again think of as one of the more centralized or central nervous system involved chronic pain disorders. They took these chronic back pain patients and put them in an fMRI scanner, and they asked them just to rate their spontaneous pain, the fluctuations that they were experiencing naturally without any stimulus, additional pain eliciting stimulus applied. And what they found is this spontaneous pain had preferential activation of brain regions that are more involved in emotion and emotional processing. Regions like the rostral anterior cingulate, the ventromedial PFC, the amygdala, and the ventral striatum. And interestingly, there were not sensory brain regions activated in these chronic pain patients. So the conclusion that they made is this centralized pain may be more emotional, more associated with emotional brain regions, at least, than acute pain. So they followed up this study with a longitudinal study where they took patients who had just suffered a back injury, and they followed them for a year. At the end of the year, some of the patients, their pain had gone away, and other patients, their pain had persisted, and they transitioned into being chronic pain patients. And they looked at what factors differentiated these two groups. And interestingly, they found that the biggest predictor of transitioning to chronic back pain was actually brain changes in these emotional brain regions. So specifically connectivity between the ventromedial PFC, which is one of those regions involved in spontaneous pain, and the nucleus accumbens, which you all know is a region involved in motivation, reward, addictions. So again, they found that this relationship was stronger than any other factor that they put into the analysis, like different pain characteristics or different treatments that they had, patients had used. So overall, there is an association between emotional brain regions and centralized pain conditions like low back pain, and as well as brain changes that show that the brain changes are actually involved in the generation of this chronic pain. So with all of these findings on stress, emotions, brain changes being associated with chronic pain, of course, the field has said, well, psychotherapy may be a great approach. So the last point by way of background is about these standard psychological approaches that are used for chronic pain. The gold standard pain treatment is cognitive behavioral therapy for chronic pain. This is the cover of the manual for CBT for chronic pain that is used in the VA, and this has been nationally disseminated. They have a national training program in the VA to teach clinicians CBT for chronic pain. And it is an effective treatment based on their published studies and also in reviews and meta-analysis. CBT for chronic pain is effective. But the problem is that the effects are small and they appear to be time limited. So these numbers are from a Cochrane review published in 2020 by Amanda Williams and colleagues. And they show that there are lots of effect sizes on this slide, but in plain English, what this means is if a patient went through CBT for chronic pain, their pain was reduced on average 0.4 points on a 0 to 10 pain scale compared to if they had just pursued their usual care. And that was even lower at follow-up into 3 months, 6 months, a year after treatment. So the effects are pretty small, although they are better than treatment as usual, not doing anything at all in terms of psychotherapy. So what about other popular psychological approaches? Acceptance and commitment therapy, or ACT, is another approach that's been studied a lot for chronic pain. This is a figure from a study by Julie Weatherall and colleagues that directly compared ACT and CBT for chronic pain. And they found there are really no differences between ACT and CBT at any time point on any outcome, as you can see in the figure. And in a 2017 meta-analysis of ACT for chronic pain, they found that same problem that CBT had, which is that it's effective, but the effects are small and don't continue beyond the end of treatment. Same thing goes for mindfulness-based interventions. This is a couple of figures from a very large study with over 300 patients that compared mindfulness-based stress reduction, CBT, and usual care groups for chronic low back pain. And they found at every time point, there was no difference between MBSR and CBT. And they follow patients all the way out to 2-year follow-up, which at that time, there was no difference from usual care either. So same situation, small effects, time limited with MBSR. So why are there smaller effects with these psychological approaches, even though there's such a big emotional component to chronic pain and especially centralized pain? Well, I think it's several reasons. These approaches don't focus on the brain's role in really contributing to the generation of the pain. So their conceptual models don't take into account the fact that pain can be reduced by intervening on the brain with psychotherapy. Instead, their approaches are coping with pain, or in the case of ACT and MBSR, accepting the pain rather than pain reduction. And these approaches, because of their coping or acceptance focus, they don't directly get into the trauma, the life stress, the relationship conflicts, and even the emotional symptoms that patients exhibit. So an alternative approach was developed by these guys. Mark Lumley is on the left there. He's a distinguished professor of psychology at Wayne State University in Michigan, and Howard Schubiner on the right. He's an internist in Michigan, actually. They published this article in 2019 that you see cited at the bottom in Psychosomatic Medicine on a different assessment and treatment approach for chronic pain that takes more into account what I talked about with subtyping the chronic pain, seeing if a patient's potentially a good candidate for psychotherapy, and then directly addressing trauma and stress. And you see that in this figure here, this algorithm that they have in the article. And so I'm going to spend most of the rest of the presentation walking through the assessment approach and then these treatment approaches that they suggest. And Lumley and Schubiner also created their own intervention called emotional awareness and expression therapy that I'm going to talk about as well, and that I've been using in my research. And I do, again, in full disclosure, consider both of them mentors, and I have spent a lot of time speaking with them and working with them on this project, the research project that I've been doing. So let's go to the assessment approach in a little more detail. We look at three broad categories when we're performing an assessment of a chronic pain patient, really focused on seeing about whether they have centralized pain and therefore may be good for a brain-based treatment like psychotherapy. So the first thing we do is try to rule out peripheral pain. So we do perform a physical examination and review imaging studies of the back if they exist, and other studies like electromyography if that's available, and try to determine whether the physical findings can completely or fully explain the pain. But what I want to emphasize again is that the centralized pain diagnosis is not a diagnosis of exclusion. So we also focus on actively ruling in centralized pain by addressing three major categories. First, we ask the patients about the patterns of their pain. That is including the distribution of the pain and the triggers for the pain and the temporality of the pain. So if they have a distribution of pain in their body that doesn't really conform to anatomy or to the findings on the physical exam or the scans, then this is more likely to be centralized pain. For instance, I have many patients that come in and say, well, I have disc degeneration at L4, L5. But we actually see that their pain extends all the way up from their neck all throughout their whole back. And so that L4, L5 abnormality is probably not fully explaining their pain. And in terms of stimuli, patients report that stimuli are a wide range of things causing their pain, like wind, light, smells, computer screens, and things like that are probably not related to nociceptive pain. It's probably more likely to be centralized if there are innocuous stimuli triggering their pain, or stress if they get into an argument with somebody and their pain goes up. And in terms of temporality, things we look for are like if they had an injury and there wasn't pain for several years, but then they got divorced and the chronic pain started up at that time. Probably the divorce didn't cause any changes to their back that started the pain at that time. The next thing is we look into their psychosocial history, and a couple things. First, we look at when the pain originated. Like I just mentioned, did the pain start after an injury? Was there no injury? Was it at a particular time of life that was very stressful for the patient? And then looking deeper into the history to see whether they had additional trauma or stress that may have precipitated something like PTSD, depression, anxiety. which is the third category, looking into their medical and psychiatric history. You all know that chronic pain is highly comorbid with depression, anxiety, and centralized pain conditions like low back pain, fibromyalgia, even more so. So the more kinds of centralized conditions they have, it may predispose their pain to also being centralized, although of course that's not necessarily exclusionary. But we ask them about their psychiatric and medical history to see their comorbidities, to see the totality of this picture if it looks like there's at least some aspect of centralized pain. So what about our patient? He had multiple medical conditions, which may have also had a centralized aspect to them, things like tinnitus and also the PTSD he had. And you can see that here. So that didn't necessarily, like I said, mean that he had centralized pain, but it means that he did have a predilection for centralized syndromes. In his psychosocial history, we looked at what happened around the time of his pain, and he did have that motor vehicle accident, but he also had a lot of stress after that accident. His wife actually divorced him when he lost his job, which required physical labor, which he could no longer take part in because of his right arm paralysis. And so there was additionally a lot of stress and emotion, anger, grief that he hadn't fully processed around the time in which the accident occurred. And he also had quite a bit of emotional trauma, particularly there were bedwetting incidents that he and all of his siblings had that were very sternly punished by both of his parents. And so finally, in his pain patterning, also showed that there was some evidence for centralization. Now, I mentioned his right arm was paralyzed, and that's where he felt the pain. So some of you might be thinking, well, gosh, there was obviously pathology in the right arm, but does that necessarily mean he had to be in pain? Well, it turns out that the pain actually came on when he urinated. That was the main trigger. And we didn't really see how anatomically there was a connection between urinating and hurting in your right shoulder. But there was that connection between the stress that he reported with bedwetting and childhood and all of the emotions that he had been holding on for so long during that time. So that was the assessment, and we thought based on all those factors that there was a strong likelihood that he did have at least some component of centralized pain despite the paralysis that he also exhibited. So what about treatment? I mentioned in Lumley and Schubner's algorithm, there are several layers of treatment, and these can broadly be divided into pain reprocessing therapy interventions and the Eaet interventions. So in pain reprocessing therapy, they really focus on educating the patients about the role of stress, emotions in the brain and chronic pain, and then performing the assessment like I just walked you through and feeding that back to the patient to make it personalized that their pain is likely centralized. And then they use largely pain exposure techniques. So there is an experiential component where if the right arm lifting causes their back to hurt, they ask them to try to lift their arm and focus on positive sensations to try to desensitize that pain response in the brain. And this is the main experiential activity they focus on. So you're probably thinking this is kind of cognitive and behavioral, but it's different from the CBT as usually presented, which focuses more on coping with pain rather than reducing it. And then the Eaet interventions that I'll talk about a little more in a moment are more focused on the processing of emotional trauma and healthy communication of emotions. So before I go into Eaet, I want to quickly just go through the research. There was a pretty big study of pain reprocessing therapy, which is why I'm emphasizing it. It was published in JAMA Psychiatry Online back in September. So it was in mostly younger adults. The average age in the study was 42, and they were 92% white and mostly well-educated patients. And the PRT was delivered by the developer of PRT, who's a man named Alan Gordon here in Los Angeles. And so they didn't really use a manual, and Alan Gordon treated, and his colleague treated most of the patients. So it was a very special study, but the results were still very impressive. They randomized 150 patients to pain reprocessing therapy or usual care or a placebo treatment. And you see here that all patients started with a relatively low, moderate pain level of 4 on a 0 to 10 scale. But the pain reprocessing therapy patients had much more improvement. Their pain dropped all the way down to around a 1, whereas the other groups, it went down to around a 3. And this was statistically significant. And you see it was mostly maintained out to 12 months follow-up. And in this diagram, you see how the pain reprocessing therapy patients, 2/3 of them had little or no pain, a pain rating of 0 or 1 on the 0 to 10 scale at post-treatment. And over 50% of the pain reprocessing therapy patients maintained little or no pain into 1-year follow-ups. And what was more impressive about this study was they actually did longitudinal fMRI on all of these patients that participated, and they did this spontaneous pain task that I mentioned earlier. And they found there was a decrease in this pain network with pain reprocessing therapy, but not in the other 2 groups here. But there hasn't been a study of PRT in older adults. I think this needs to be replicated in more diverse populations and with some sort of treatment manual, which is really required for research studies of psychotherapy. So very quickly on Eaet, it is a manualized treatment, and there are 1, 3, and 8 session manuals that have been tested in research studies on different pain conditions, medically unexplained pain, a study of chronic pelvic pain, irritable bowel syndrome, actually, and a large study of fibromyalgia. It was 230 patients randomized to 8-session Eaet, CBT, or education control. And in each of these studies, in contrast to the psychotherapies I mentioned earlier, Eaet showed medium to large reductions in pain, as well as pain-related distress and disability. And in the fibromyalgia trial, there were some advantages over CBT, such as the number of patients with large or greater than 50% reductions in their pain. So I met Lumley and Schubiner in around 2017. I was aware of their work actually from Dr. Katzman earlier than that, but I started talking with them and I set up a clinical trial here in Los Angeles with older veterans. And these are the results of my pilot study I'm about to present to you with 53 older veterans that we randomized either to Eaet or CBT that we delivered as 1 individual session and 8 90-minute group sessions in small groups of 6 to 8 veterans. And this was published in the journal Pain Medicine in 2020. We did see in the study a large and statistically significant advantage of Eaet over CBT for pain reduction, both at post-treatment here. You see this line, this dot is Eaet pain scores, which were substantially lower than CBT pain scores at post-treatment. And at 3-month follow-up, you see that the Eaet patients also maintained their reductions in pain to follow up, even improved a little bit more on average, whereas CBT, like I mentioned in the reviews earlier, the patients kind of went back to the same pain level at follow-up that they had started with at baseline. And as far as large improvements in pain, at 3-month follow-up, over 40% of our Eaet patients had greater than 30% pain reduction, which is clinically significant pain reduction in the literature. And you see over 20% of the patients had greater than 70% pain reduction, whereas none of the CBT patients met any of those benchmarks at the follow-up time period. So I wanted to repeat this study, of course, in a larger sample. So I did receive my grant from the VA to do a 5-year study with 160 veterans randomized to Eaet or CBT. And we started that study, but of course, then everybody knows what happened. And so we put a hold on that study. We considered various plans. We had these clear masks that we found that were used actually in the ICU in a hospital in Oregon so that we could see the emotional facial expressions. That was something we thought was important in Eaet. We also considered having the groups outside. And of course, everybody said to me immediately, well, why don't you just move the groups online? But we had older, complex, racially, ethnically diverse veterans, and I was pretty hesitant to do that. But we did try. So we took veterans who were over 60 years old, and we sent them a tablet computer and provided them with tech training over the phone. This was in late 2020. And we sent them this manual, which was in color, that taught them how to use the tablet. And then we delivered the 9-session Eaet, including 8 group sessions over Zoom. And we did outcomes at baseline, post-treatment, and at 2-month follow-up. And you can see here we did 3 groups. The first one had 4 older veterans. The second and third had 6. It was an older group. If you see down here, average age was around 71, and it was racially, ethnically diverse with 69% of the participants being Black. And it did work. They started with a pain of about 5.5 and went down to around 2. Overall, it was a 58% reduction in pain. And 3% of the patients had over 90% pain reduction, with one patient having complete total 100% pain reduction at post-treatment. And the follow-ups and secondary outcomes are still in the works on this study, but we were very excited by these results and thought we can, in fact, do this intensive emotional intervention online. So hopefully that's gotten you a little curious about Eaet. So I want to talk a little more about what we actually do in the group. And Lumley and Schubiner, as I mentioned, developed Eaet, and they published this article also in 2019 that describes the development of Eaet and basic techniques. So Eaet has multiple inspirations, including the pain neuroscience that I talked to you about, as well as ISTDP, which we talked about at the top of the hour. And that's really how I came to Eaet. During my residency, as Dr. Katzman mentioned, I was introduced to ISTDP by him and Patricia Coughlin. But I also had a strong interest in research, and I wanted to actually do research on ISTDP. But there were several problems in that for a big grant, they really require manualized therapy, something time limited, which is not the case with ISTDP. So Patricia actually put me in touch directly with Howard, and I spoke to him and said what I wanted to do. He put me in touch with Mark, who was more the researcher and had gotten that R01 to do that large study in fibromyalgia. And so he became a mentor, and I looked at their Eaet manual, which shared so much in common with ISTDP, and I thought was great. And I said, this is what I want to do. So that's how I started my study and my interest in Eaet as well as ISTDP. So the conceptual model for Eaet is that all sorts of stressors cause emotions. And the key thing is, do we experience those emotions? Do we face them? Do we acknowledge them within ourselves? Or do we avoid them? Usually through the habitual use of defenses, although sometimes intentionally. And Eaet asserts that if we do avoid our emotions, especially painful or difficult emotions like anger and grief and guilt, then that can result in chronic pain in certain people or other symptoms. And also it's associated with those brain changes. And so where Eaet acts is really to help the patient learn to experience those emotions and try to reduce pain and other symptoms. And we hope that that will help normalize the brain pathways that I've been talking about with chronic pain. So Eaet has several components. It's not just open-ended like ISTDP, but there are handouts, there's psychoeducation about pain neuroscience provided, as well as about different emotions. There are lessons on anger, on guilt, on stress, of keeping secrets, on forgiveness. And then we have experiential exercises, which really are when we invite the patient to bring in some stressful event for their life and face all of the difficult and painful emotions about that experience in the safe context of the group. And then we have homework assignments that are aimed at helping the patients make these connections between their pain and emotions and events in their lives, and also written emotional disclosure exercises to augment the in-person experiential emotion disclosure exercises. And so this is a model of the type of emotions that we go through, and another version of the conceptual model, which is that when we're hurt, whether that hurt is physical or emotional, then we either have a typical cascade of anger and grief and guilt and sadness and longing over here on the right, or we're scared of these feelings and we engage in avoidance, which leads to pain and other symptoms. And so in Eaet, we usually have to go through this cascade of feelings to try to reverse the avoidance and change those brain pathways that are involved both in emotion and pain. So how do we do this? We first teach the patients about the difference between experiencing their feelings in their body and then expressing their feelings, which is the action. And so we, as far as the experience, we ask them to label the feeling, describe how the feeling feels in their body, which this is a 2014 study that indicated that patients do feel feelings in their body. That's something that I learned at UNM. I was all intellectualized medical student in my head, but feelings actually are in the body, and there's research for that now. And then we describe impulses, which are what the feeling makes you want to do, and discussing all of those in the group so they become less scary. You don't have to avoid them. And we find that that makes the patient actually less likely to feel the need to act on their feelings, and also helps them feel relief and reduced pain to get these feelings out in the open and share them with other group members and the therapist. So in our particular case, the patient, Mr. C, he had worked through several feelings, including anger towards his mother and compassion towards himself and a child, focused on those bedwetting incidents that were so painful for him. That was, like I often say to patients, that was the pain of his life. And that's what we addressed in his Eaet therapy. And he was one of the patients at the end that had over 50% reduction in his pain. And he also started getting back out there and living life again. He had a hobby of being an artist and wanting to draw, and he started doing that again. He hadn't done it for decades since the motor vehicle accident, and also was planning a fishing trip, which he hadn't done that either in many, many years at the conclusion. So a successful outcome for this case. So the limitations of this approach overall, you may be thinking this is not easy for the therapist, who has to be really focused on helping the patient and able to tolerate intense emotional expressions by patients. And it's not easy for the patients that we are asking them to discuss the most painful experiences of their lives. And I think we have to provide very clear, informed consent about what this therapy is all about when we sign up the patient for the therapy. As you can see, not everyone responds, not everyone wants to participate in the therapy, which is what I would say is a limitation. The mechanisms and key components, I think we need additional studies in different populations that focus on psychological mechanisms and neurobiological mechanisms. There's a lot of theory. There's a model that I presented about the emotional pain circuits for centralized pain, but that needs to be tested and whether Eaet actually acts on those circuits. PRT is also not yet manualized. I believe the developers are working on that. And then finally, in this entire algorithm, I think it needs to be determined when PRT is enough or when they need to get into the deep emotional processing, and the whole algorithm has not yet been tested. But there are many strengths that I've gone over, such as the fact that pain obviously can be reduced in some patients using psychotherapy and neuroscience, and when the pain is centralized and involves the brain and emotions and stress. And I want to mention pain interference. That's the big outcome that they use in studies of CBT and other approaches. It's on par with CBT in my pilot study and in the other Eaet studies. There is a low attrition for patients who participated in all the studies. My pilot study was actually had the lowest attrition. There were a couple of dropouts, and so it was 85.7% completers. Other studies, like our online study, there were actually 100% of the patients completed the therapy, because I think, again, we provided real informed consent about what they'd be getting into, and patients made a choice that they wanted to do it. There is ongoing research. It's being tested in multiple formats, multiple different sessions, online, in person. There's actually an online self-help Eaet that a team in Sweden used. Daniel Marotti was the first author on the paper that was released late 2021. So that's an advantage, that it can reach more and more patients. And an editorial that was written about my study is that Eaet does appear to be a treatment of choice for centralized pain. So next steps for me are to complete my large study. I'm collaborating with an imaging colleague to actually do fMRI pre and post Eaet, like you saw in the pain reprocessing therapy, and test the entire algorithm. But I really think we need a paradigm shift in the field of pain medicine along the lines that I've described, using subtypes, trying to match patients with the most optimal and appropriate treatments, and to try psychotherapy if there's not something seriously wrong that needs surgical or medical intervention. I mean, what do they have to lose if they really want to do that? Psychotherapy is not going to cause side effects like opioid pain medications, potential for use disorders, tolerance, dependence. So I think it's a great option that can get out there more. So in conclusion, if you'd like to learn more, there's been a surprising amount of popular interest in these approaches. When that pain reprocessing therapy study came out in JAMA Psychiatry, there was this article in the Washington Post that was written, and a New York Times article. They mentioned both pain reprocessing therapy and Eaet. There's a documentary on PBS called Pain Secrets that interviewed Mark Lumley about Eaet that was just out, I think, 3 weeks ago. You can still find it online. And then this documentary, This Might Hurt, which follows one of Howard's Eaet groups in its entirety and out to 1 year follow-up. And they actually, the patients allowed the cameras in the room to observe the therapy. And so it's really interesting that you can see more exactly what Eaet is like and see the outcomes from a group of patients. So I really recommend that documentary as well, if you are interested. And of course, if you want to find out more, talk more, you can email me. My email address is here on this slide. And I would like to thank UNM Department of Psychiatry, my dear friend and mentor and colleague, Dr. Katzman, Lily, who helped with the administration of this talk, and all of my wonderful collaborators and mentors that you see listed on this slide. So thank you very much. I'm happy to take any questions.
Brandon, thank you so much. It's just an honor to hear you in your career and providing such an important and esteemed talk. We have a couple questions have appeared in the chat, and Dr. Romo has his hand up, so I will turn first to Paul.
Okay. Hi, Paul.
I'm sorry, I'm on a computer without a camera, but it's great to see you.
You too. Great to hear you.
Yeah, I look the same except more grays. Anyway, how does this model coincide or fit along with the pain matrix model?
Yeah, so the pain neuromatrix you're talking about, right? That is something that is pretty widespread in the pain literature. So there was initially, in going back to the 60s, the gate control theory of pain that was really the first thing to say that the brain was, and also the spinal cord, but really the brain was involved in the regulation and processing of all pain experiences. And I think the neuromatrix was an evolution of that by the same group that was, article was published in 1999 on that showed that some types, again, of chronic pain, most notably phantom limb pain, can really be generated by the central nervous system. Obviously, in phantom limb pain, if you don't have a foot and that's where it's hurting, then it can't be pathology in the foot that's fully accounting for the pain. And so the authors of that model really began to suggest that some types of chronic pain can be generated, not just augmented by the brain, and therefore acting on the brain can help. So I think it's very much in line with the model that we're proposing here, and it's part of the rationale for the different subtypes of chronic pain.
Thank you, and excellent presentation. Appreciate you.
Thank you.
Brandon, Molly Faulkner also was greatly appreciative of this mind-body connection, as I think we all are. And there was a question in the chat from Dominique about gender differences, both in, I think, the experience of pain and this therapy. Of ideas about that?
Yeah, that is a wonderful question. And most of Mark Lumley's studies that I talked about, the early studies of Eaet, they were almost exclusively in white women. And so it was quite unsettling, if I may say that, to Mark Lumley, that I wanted to do it in older men, veterans. And he was a little bit skeptical at first about whether that was going to be possible. And I think we were all pleased and surprised that based on my pilot study, at least, it seems like Eaet is also an effective treatment for men, although of course we're confirming that in a larger sample. But I think there are gender differences in the experience of pain and gender differences in emotional processing. And one of my theories about that is that maybe Eaet is a good treatment for men because maybe the average man has farther to go, more to learn, and so they can benefit from the approach as well, more to learn about their emotions, I mean. So I think that's a great question, and very interested in that in the larger sample, looking at a sample with both men and women, and also different racial ethnic backgrounds as well.
Hey, Brandon, I have a question for you. So in the ISTDP model, we talk about kind of the fragility of the patient and where the anxiety is, and is it kind of in striated muscle where we see breathing, or smooth muscle, or more disorganization, telling us about fragility? Is that taken into consideration at all with people in your group, or how is that handled, like different levels of fragility in the patients that you're working with?
Yeah, honestly, we try to exclude patients who really have signs of fragility, because patients who come in and even hearing other veterans go into great detail about their trauma and sometimes very, very difficult emotions, lots of anger and rage that are expressed in the group that we think a patient with fragility might have a lot of trouble even hearing that. And so for the study, we have some screening procedures, an anxiety assessment, and I do like a pre-interview with all of the potential subjects for the patients, and really talk to them about what the study is about to try to make sure it's a good fit for them. Because we don't want anybody to have a bad experience in the group. So I definitely think that's a concern. I don't think it's appropriate for patients that in ISTDP we might call fragile patients because of the group setting. But in individual EAET, which is something that's done, I think that it could be a more graded approach that might be more appropriate for a larger range of patients.
And I saw there was the kind of two cascades of one of the feeling, one that seemed kind of more defensive. And is anxiety part of the model also, and how anxiety is driven by our feelings, or is that not so much in the EAEP model?
Yeah, there are so many different diagrams that I should have shown, and I was up to the last minute, like putting some slides in and taking some out, because that cascade, the branch point after the hurt, is something that Howard teaches, but it really is the triangle of conflict. And in the EAET manual, they use the triangle of conflict.
There is an anxiety vertex.
Yeah, with the feelings, anxiety, defense. And we teach that to the patients. And what I do in the group is actually draw it up on the board. And so I, as the patient is talking, actually pointing out which corner of the triangle they're on and feeding that back to the patient so they can start learning and integrating that. So it is more directive than ISTDP in that way. I don't think that's something that's commonly done in ISTDP, but I really enjoy it, and it seems to work, and the patients really pick it up. But yes, absolutely, we use that triangle, and occasionally triangle persons too, I discuss with the patients, especially if there's something going on in the T in the group.
Great. Other questions? Here comes Dr. Dunkley.
Hey, Dr. Dunkley.
Great to see you again, Dr. Yarns. Thanks for coming. Thanks for such an awesome talk. You know, I just was thinking about you the other day because a patient came in, a resident, and I we're working with this patient who asked us for psychotherapy referrals and started asking about CBT, specifically asking us, isn't CBT the most evidence-based type of therapy? And just always love to hear from someone with your experience and the kind of work you've been doing the past few years. How would you answer that question these days?
So the answer is yes. I mean, CBT is evidence-based. And in that Cochrane review, there were 59 different studies of CBT for chronic pain, which is a lot to me. So what I would say is what I said to you, though. I said that comes with a caveat, which is that for chronic pain, the size of the benefit that you get is probably going to be small. And all times of CBT, for depression, anxiety, you get larger benefits. But there's a problem that plagues CBT, which is that follow-up after the end of treatment. If the patient doesn't keep up the exercises, if they don't keep up the practice, then the symptoms come right back to where they were in the first place. That it really is something that, and the same thing with mindfulness. They call it mindfulness practice because it's an ongoing thing that has to be kept up. And what we're trying to do as an alternative is not just teach a practice to like cope with it, with the symptom, but to actually get all the way to the bottom of it and figure out what's driving it, what's the engine of this problem, and address that to try to completely resolve it. And that's what the difference is in the approaches. And so that I say that to the patients when need be.
Great. Time for one last question or salutation to our former trainee here.
Yes. Well, one more
Anyway.
thing about that is, another thing I learned at UNM, it popped into my head when you were asking your question, Lucas, was that the absence of evidence is not evidence of absence, right? So just because the study hasn't been done yet doesn't mean that it's not effective, right? But we do now have lots of studies on ISTDP for chronic pain and EAET, which is an ISTDP adjacent approach as well, and we're working on it. But that's something else you can say.
Love it. Thanks so much for coming to share your work.
Thank you.
Thank you, Dr. Yarns. Thank you, everybody, for joining today. And we will see you next week.